But I would like to tell you a little bit about some work we've been doing, some thoughts on, let's say, trust and transparency in health supply chains, the way we produce healthcare. First of all, healthcare, it's in change. We have an aging society, we have a lack of personnel, and digitalization is, well, in its infancy, to say it in a positive way. And therefore, I really see that we need new methods for systems development. We need to think in a different way and test early, think about the multi-scale characteristics and logistics principles. Well, of course, I'm preaching from my own choir, but I think they're very interesting here. A little bit of theory. Sorry, I'm a professor. Um, I base a lot of what I do on both complex adaptive systems and socio-technical systems theory. And what you could very often people mix these up, but for me they're related. This inner circle where you see agent A, agent B, and some components, this is really socio-technical systems theory. We have people, agents, that have roles to try to get an optimal functioning of a system. Whereas complex adaptive systems do not see people as agents, it sees people as actors. The fact that we have bad coffee or we had a fight at the football club may influence the way we actually work with our patients while at work in a hospital, for instance. And the other thing that really strikes with me is if we think about complex adaptive systems, we need to think about aspect systems and not just about subsystems. So we should not think about healthcare. We should think about what are all the systems that people live in that influence their health, which means that it is equally important to pay attention to living circumstances as it is to the provision of pills. Even healthcare, there are papers that say like, okay, healthcare is a complex adaptive systems. We need to actually try to put the patient in the center. Everyone agrees on that. But how to do that? How can we look at care pathways? How do we look at integrated care, preventative care? And very quickly we lose the focus on the patient because the patient is an object for our production rather than the one around which we center our production. In health data, I guess I've been online in the stream a bit. I mean, this is what is going on. Massive amounts of data are created, both quantified self everyday things that you can do with your smartwatch or whatever collects your data, but also the massive amounts of biological data, clinical data, preclinical data that are produced. And all of this is relevant, but where is it relevant and in what way? And how do we consider this data? For me, there are two big crises that I try to work on. And the first one is we cannot afford the aging population. Very simple. We have too few people to be able to treat our elderly. Even if we can get more healthy lives, in the end, we're all going to die. And given that we're all going to die, we all need some form of support in the last years. So absolutely impossible to afford that with the current way we provide healthcare. The other thing is when we think about mental health, what you see is that there's a left shift of the mean. People are feeling worse. And that is not just increasing the number of people that need psychological help or psychiatric help, but it also reduces the number of people that are thriving and excelling and therefore are the ones producing a lot of the value into the economy. For me, this means that we need to start thinking about how do we produce health and how do we produce health care. And here, if you follow Herbert Simon, that shows I'm aging. Yes, I'm getting bald. But you need to think about healthcare not just as a medical science, but really as a system. It's a science of systems. You have all kinds of inputs that produce in a hospital, in a ward, in a doctor's clinic, but also digital services, of course. You have unmet demand, which is massive in current society. So if we look at our data and think that our data represents the medical demands, that might not be the case. Maybe it just measures what we treat, which is a very different thing, because it also sees like, okay, but uh, is healthcare safe? If healthcare is not perceived safe, people will not go to a doctor. Is healthcare accessible? I live 1 hour south of Stockholm on an island, next to Nynäshamn. For me, the nearest doctor during office hours is a 25-minute car ride. If there's something with my kids, I have small kids, I need to get into a car, 40-minute drive to the nearest health clinic. My kids have seen far fewer doctors than the kids of my colleagues who work here in the inner city because they have everything near. So are my kids more healthy? Maybe. But I actually believe that what we measure here is accessibility of the health system. Now, what you see globally is a push towards what we call flipping the pyramid. At the moment, most money and also attention goes into tertiary care, secondary care, and there's very little money in preventative and public health care. It's about 3% of the entire health budget goes towards preventative and public health at the moment in Sweden. 3% is on the positive side. But what you actually want is, and this is something from India, but it's very similar everywhere. You want to provide as much preventive and public health care as possible to make sure that you get the least pressure on the more expensive things that you need to provide. Keeping people healthy is an economic very good case. So we do a lot about studying healthcare processes. We do what we call process mining, looking at data, trying to identify the different healthcare processes and the different pathways that people take to see like, okay, but in what way can we treat people effectively? And of course, like everyone at the moment, we do prognostic analysis. Very simply looking at like what are the consequences of, for instance, certain treatment pathways, which ones have a better survival rate, which ones have a better effect. All data-driven, relatively harmless work if your data is correct. And this is where actually I have my big doubts. Because data is not new in our domain. The Swedish public sector has always been steered by the principle of evidence-based. But what is evidence? What is reality? And you need to capture the data from reality. You need to have models about the meaning of this data. You do computation for processing. You have storage systems. You have tools to give meaning to process data and pathways to convert all of this meaning into decisions. But every step is subject to reduction. We throw away certain insights, outliers, things that do not fit us everywhere. And if we already know that the source data is so biased, how do we actually believe that any decision that we make based upon data is a data-driven decision that is just, fair, and maybe you can think of other acronyms, but something that we can rely on as something that is a part of our democracy? Is very, very difficult. And for me, a really important thing is that I see that stakeholders shape the system. And this is very often, we have such a natural sciences perspective on the way we produce data that we see like, okay, here we have an amount of treatment data, for instance, about a patient. But do we know why this patient, this elderly lady, actually had a different pathway than another person? Could it be because of character? What we see in elderly care is that a lot of this is undocumented. It is with the personnel. And as long as this never makes it into a computer, we do not consider it data. whereas it's very, very important for actually providing good health and good healthcare. It's also like who has a mandate? You see that incentives for providing data, for using data in the right way, they're very different at the different levels. And then here is just a list of Swedish and European laws and regulations. It's not entirely rule-free, to say the least. For me, the really big thing is AI for systems change in health is meaningless if we do not represent the stakeholders. And in design theory, actually spelling error there, this is already rule number one. So why do we ignore this in AI where we are so um, uh, focused on ground truths, etc.? I don't believe in ground truths anymore. Are we aware of this? Well, we did some processes, a process analysis on a hospital, Academiska Hospital. We just published that in Nature. We're a little bit proud. But what we showed there is that depending on the data labels that are set by the first nurse that sees a particular patient, the pathways that elderly people follow within emergency care, so geriatric patients, are entirely different. They get different health processes, just the way we put the data labels. And there is no evidence that these data labels actually represent a good reality. They could be just personal variations. What we also see here in the lower picture is the number of, in Swedish, orosanmälningar, so the social reports about like there could be something wrong around this person, and divided over age in leading a municipality. And what you see there is a big dip at 16 and then really like going down after 19. Do we really believe that people at 16 and 20 feel so much better than people at 15 and 17? That there are fewer problems? No. 16 is the age where you go from secondary school to gymnasium in Sweden. So this is the age where there's a change in the system, and therefore we see fewer reports. We don't know the kids there. And from 20, then people are considered adults. They're no longer in the school system. So we also see a drop. And also the question becomes like, what numbers to focus on? The left-hand paragraph is the number of observations of different types of indications for the youth psychiatric care in Stockholm versus the time between the first request for help and the first meeting with a doctor. And in Stockholm, the timing is 30 days. And what you see is actually that BUP, as it's called, is actually doing a rather good job if you look at the average. But why does it have such a bad reputation? Well, we started to look at the tails. And what you see is that the tails, for instance, here at the top, this is days. So there are people here that have been waiting for 10 years between the moment that they were reported for like they need help and their first visit under the same code. So this is not that this person like was referred wrongly, etc. So there are tremendous waiting times here that really do not help people. And if you start looking into healthcare, what we notice is don't look at the averages. Look also at the entire distribution and particularly the extremes, because it's these extremes that really put pressure on the health system. For me, it then comes to like, do not just do data mining and AI because it's a rearview mirror and it's imperfect. Also, think about simulations and ways in which you can add the causal relations. And preferably on top, play with your models. Do interactions with your models. And if you do it like that, you get this human insights layer on top of a system dynamics layer and structure observations. Here I skip a little bit for time. But again, this is not new. Even the late 1990s, these books, particularly the Black Book by Morgan, is really, really nice. Reasoning with models, models as mediators. It's a known way, but we tend to forget this when we start looking at data. A little bit about cost structures. What you see in healthcare is that there's usually a judgment based upon a study of like, is it effective to provide a certain type of care? And what you see is rather well developed in health economics. This is called QALYs, qualitative years added um, uh, to a life. And then you get different types of cost curves here where they try to, this is HPV vaccinations, and they did a study of like, okay, if we uh, uh, do the program in very different ways, for instance, if we also vaccinate boys, then all of a sudden our costs go up, but the amount of QALYs, qualitative years, gained for the population is less. So it's more expensive to do that. This is a very robust but also reductionist way of looking at data, because very often this is data that is just at a regional or national level. But how do we think about all of these filters, all of these governance steps that are done between overarching reports and really the way healthcare is delivered? Because for me, reality is where the treatment happens. And on the left-hand side, you see the classical randomized clinical trials. This is from my colleague Adam Darish. All kinds of effectiveness studies, follow-up studies, stage 3, stage 4 for medicine. But most of these studies are done, for instance, on healthy males between 18 and 35, whereas on the right-hand side, you see a better representation of the population. So we need to start looking at this real-world data that is really a representation of reality. And you get into real-world data as stage 4 clinical trial, for instance. Last bit, if we think of data-driven and evidence-driven or knowledge-driven, we did some work on cancer treatment where we got real-world data. And what we noticed is that even if we make a data model pipeline and we validate, we can find all kinds of things. But the feedback and the interpretation of that data is impossible to do without the clinical knowledge. But what we also saw was, even if we produce outcomes and we ask people then to like tell us what we see, there is absolutely no way that this becomes something valid. You need to do this multiple times, by which you actually start thinking like, okay, now we learn something, but with that, we actually start treating our data in a different way. We annotate our data in a different way, or we even ask different questions. And if you start doing this looped after another, only then you actually start producing good science. I thought about stopping here.